Today, we're focusing on a class of drugs you'll definitely encounter: beta blockers. Our aim is to give you, our medical student audience, a really solid understanding how they work, why we use them. We'll follow the typical sequence you see in pharmacology resources, step by step. Ready to jump in?
Absolutely. Let's start right in the beginning.
Yeah.
Administration.
Mhm.
How do we give these drugs? Well, there are quite a few ways. Orally is common, tablets, capsules. Some are even extended release, like Metoprolol XL. Then for urgent situations, there's IV injection. Esmolol is a good example there. And even eye drops like Timolol for glaucoma. Oh, and also a topical gel, propranolol gel, for treating infantile hemangiomas. So it really depends on what you need it for.
Okay, quite versatile. So once it's administered, how does it actually work? What's the mechanism?
Right, the mechanism. Fundamentally, they block beta-adrenergic receptors. After the drug gets absorbed and into the system, it finds these receptors primarily beta-1, which are mostly in the heart and kidneys, and beta-2, which you find more in places like the lungs and blood vessels. By binding to these receptors, they basically stop the body's own catecholamines, things like adrenaline and noradrenaline, from activating them.
Okay, so blocking the messengers. Let's focus on the heart first. Blocking beta 1 there, what does that do?
In the heart, blocking beta-1 has three main effects. First, it slows down the heart rate. We call that negative chronotropy. Second, it reduces how forcefully the heart muscle contracts. That's negative inotropy. And third, it slows the speed of electrical signals through the heart negative chronotropy. Put those together, and the overall result is that the heart pumps out less blood. Cardiac output goes down.
Less work for the heart. You also mentioned beta 1 receptors in the kidneys. How does blocking them play a role?
Yes, the kidneys are important too. Blocking beta-1 there reduces the release of an enzyme called renin from specific kidney cells. And less renin means less angiotensin II and less aldosterone are produced down the line. The effect of that is it helps lower blood volume slightly and also helps relax blood vessels, reducing what we call systemic vascular resistance.
Interesting. So combining the heart and kidney effects, what's the big picture physiologically?
Well, the big picture is that by slowing the heart and reducing its force, you decrease how much oxygen the heart muscle needs. And as we just discussed, through effects on both the heart and the renin system, they effectively lower blood pressure and help control heart rate.
Okay, that makes sense. So clinically speaking, when do we actually reach for beta blockers? What are the main uses?
The indications, they're used for quite a lot, actually. Hypertension is a big one. Angina pectoris, too. Also, for managing certain heart rhythm problems, arrhythmias, especially the supraventricular types. Some specific beta blockers are very helpful in heart failure, though not all. They're really important after someone has a heart attack, post-MI. And then there are other uses like preventing migraines, treating essential tremor, helping with anxiety symptoms, and like we mentioned earlier, glaucoma via eye drops, and infantile hemangiomas with the topical gel.
A wide range of uses. But of course, there are potential problems. What are the major adverse effects we need to keep in mind, especially for exams?
Definitely need to know the side effects. The big ones are bradycardia, the heart rate getting too slow, and hypotension or low blood pressure. Fatigue is common too. A very important one, especially with non-selective beta blockers, is bronchospasm, which is risky for patients with asthma or COPD. They can sometimes worsen heart failure if it's already decompensated. Another key point, they can mask the warning signs of hypoglycemia, low blood sugar, in diabetic patients. That's crucial. And some people experience sleep disturbances or cold hands and feet.
Right. Masking hypoglycemia is a classic exam point. What about interactions? Do they clash with other common drugs?
Yes, interactions are critical. Using them with other blood pressure lowering drugs can cause blood pressure to drop too much additive hypotension. Combining them with certain calcium channel blockers, specifically verapamil or diltiazem, can significantly slow the heart rate, even causing heart block. That's a serious one. We mentioned the issue with anti-diabetic drugs and masking hypoglycemia. And interestingly, NSAIDs, common pain relievers, might actually reduce how well beta blockers lower blood pressure.
Okay, so definite things to watch out for. Are there times when you absolutely should not use beta blockers? Contraindications?
Yes, absolutely. Clear contraindications include severe bradycardia or significant heart block, like second or third degree. Also, acute decompensated heart failure when the heart failure is actively getting much worse. For non-selective agents, severe asthma or COPD is usually a no-go, and conditions like pheochromocytoma unless an alpha blocker is used first, and severe peripheral artery disease.
Got it. So finally, if a patient is on a beta blocker, what do we need to monitor?
Monitoring is key for safety. You need to regularly check heart rate and blood pressure. That's fundamental. Watch closely for any signs of worsening heart failure. In diabetic patients, monitor blood glucose carefully because of that masking effect. And for anyone with lung issues, keep an eye on their respiratory status, listen for wheezing.
Excellent. So we've covered the journey administration, mechanism, effects on the heart and kidneys, the overall impact, clinical uses, those important side effects and interactions, contraindications, and finally, monitoring. For everyone listening to KMR Advise, especially you medical students, these are really fundamental principles about beta blockers to grasp.
They really are. Understanding beta blockers is crucial for managing so many conditions you'll see. We hope this breakdown helps. Keep thinking about how these drugs work in different patients. And please, for more deep dives like this from KMR Advise, do subscribe, share this with your colleagues, and hit that bell icon so you don't miss out. Let us know what other questions do you have about beta blockers, and what other topics should we tackle next time on KMR Advise.